A very warm welcome to one and all who have been participating from across the globe for today's very interesting session, one of a kind when we talk about a masterclass series, but in a webinar form with one of our own very special doctor, Dr. Shakaib Quereshi. As you all know that Dr. Qureshi has been an advocate and a fellow when we talk about, advancing digital science in the space of rheumatology. He has been a core academician as well as a guide, not only to all the fellow doctors at MedSynapse, but to various parts of the world when we talk about the various nitty-gritties of rheumatology and advancements, when we talk about majorly in the real-world evidence. Dr. Shakaib Quereshi has engaged with us with one of the very interesting sessions, which was gout management, a live session, which is still there in the archived version, and also one of the masterclass video recordings, which was focusing on the management updates on rheumatoid arthritis. Today, the focus is on a very pertinent topic that is myositis. And more interestingly, we will be dwelling deep into the various norms and decoding of the various, given presentations as well as situations and understandings in this particular space. All the questions that has been drafted over the time and shared by the doctors across the globe will be answered today through doctors' expert opinions. Thank you so much, Dr. Shakaib Qureshi, for joining us today.
So good morning and good evening wherever you are. It's actually morning here. And thank you very much, the whole team of MedSynapse. They are amazing. And thank you for giving me this opportunity. So thank you very much. And let's start whenever you're ready.
Sure. So, Dr. Shakaib, we will divide this session into two parts where we focus on the diagnosis of myositis first, and then we move along with the management aspects. So the first question that one of the doctors from Singapore he has presented is when we talk about the importance of muscle biopsy in the diagnosis of autoimmune myositis, what is your purview? And also, if you can elaborate more deep when we talk about the histological differences between dermatomyositis, polymyositis, and muscular dystrophy.
Okay. Yeah, very good question. So let me actually first give a brief introduction of, all these autoimmune muscle diseases, because it's very important that there will be other listeners who would first want to know what we mean by polymyositis and dermatomyositis and autoimmune muscle diseases, and then we'll quickly touch upon the muscle biopsy part. So since I've been doing rheumatology for the last 20 years almost now, we have come a long way in how we deal with autoimmune muscle diseases, idiopathic autoimmune muscle diseases. So first, anybody who comes to our office, we have to first find out whether this is an autoimmune muscle disease or not. So like any other illness that we deal with, we have to take a very proper history, then going through the physical examination, and then the lab work, and then subsequently the muscle biopsy is talking about. So the first step is that anybody who comes to us mostly would not say that he's got polymyositis. So typically an internist would have referred to us because of the high suspicion. So the first step when somebody comes in, we want to make sure that it's not a neurological disorder. It's not something which is due to drugs, due to toxins, or due to a whole list of things which can cause weakness and fatigue. Once we know that this is probably an autoimmune muscle disease going on based on the history, then the examination portion would be able to give us a few clues. For example, the skin findings and then the muscle findings, which we'll discuss in detail as we go along. And then we order the pertinent blood work, which includes CPK, LDH, SGOT, SGPT, other testing, which is very important, is myositis, autoantibodies, which we'll discuss in detail because they're all very important. So first question, the first answer, I'll actually really want to touch upon the autoantibodies soon after we finish the muscle biopsy portion, because that's very important for all the rheumatologists and internists to realize that all the diagnosis and the treatment is mostly based on these autoantibodies, because they determine the phenotype and then they determine what kind of a treatment we'll be giving them. So once we have figured out that this could be probably an autoimmune muscle disease going on, now the next step typically is to order an MRI scan of the involved muscles or the suspected muscles. Sometimes a whole body MRI can be done of the muscles, so that we know the burden of the disease and the location of the disease. Previously, and still, we use EMG or nerve conduction study of at least one of the limbs to find out whether it is a myopathic process or a neuropathic process going on. So the EMG utility is pretty much now only kind of few indications. The main indication is to rule out neuropathic from a myopathic process. And the second part is in the subsequent management of the disease to rule out whether it's because somebody can improve with the treatment and later on can develop muscle weakness again. So it is the second part is to differentiate between whether it's a steroid-induced myopathy or a recurrence of the disease. So the most important point to remember is that if you do an EMG of one of the limbs, then you do not take the muscle biopsy from the same limb, because that particular muscle can remain abnormal for the next 2 years almost. So it will be contraindicated to get the muscle biopsy from that particular muscle group or that particular limb. If the MRI is not available, you will do the muscle biopsy from the opposite limb where you found the abnormal EMG or nerve conduction study. For example, if you do it on right leg, then the muscle biopsy should from the left leg and vice versa. If a muscle MRI scan is available, then you rather do the MRI scan as a first step, and then you can locate the actual muscle or the number of group of muscles which are involved. Once you know the muscle is abnormal, then you will now arrange a group of people who will help you out with arranging the muscle biopsy. The most important members of this group are the surgeons, because you have to have a very good surgeon who knows what he's doing. And then anesthesiologist, you have to tell the pathologist and surgeon, and they have to coordinate the care with each other, so that it's a very important thing that the proper specimen is taken and then proper processing is done by the pathologist within a very short period of time, because there's a limited time during which you can do. Now, if a tertiary care center is available where these things are done over and over again and repeatedly done, then it's very important that this should be rather done at a tertiary care center who knows what they're doing, because this is an invasive procedure and you should not be subjecting the patient repeatedly to this thing. So few of the important things which are very important is the selection of the muscle involved. So once you have selected the muscle involved, the most important pitfall is that you have to select the muscle which is still not completely gone. The muscle power of that muscle should at least be 4 out of 5 or 3 out of 5, and not completely destroyed muscle. Because if you're only going to get a muscle which has advanced disease, you're not going to find much. You're only going to find is adipose tissue and advanced fibrosis. So selection of the muscle based on the MRI guidance and your physical examination is very important. The next step is the open muscle biopsy has to be done, not a needle biopsy. The open muscle biopsy should be done, and at least 1 centimeter piece of tissue should be obtained in the adults. Obviously, in kids, you're going to do a smaller piece of tissue. And then tell the anesthesiologist not to inject the anesthesia directly into the muscle. It should be a very superficial anesthesia, because if you inject the anesthesia directly into the muscle, you can destroy the muscle. Another very important point to tell to the surgeon is that do not use the electrocautery, because if you're going to use electrocautery while trying to get the muscle, then you can damage the muscle fibers and you may not be able to get the proper. So whole exercise will go waste if you don't take these precautions. So these are very important points you have to tell. Once you obtain the specimen, typically 2 or 3 specimens are obtained, and you have to, the stretched specimen is, basically packaged in a saline gauze and sent to the lab quickly, where a technician and a pathologist should start processing the specimen pretty quickly, typically within 3 hours. And then you have to properly, do the fixation and the staining of the specimen, because this staining is very important. You have to look at different enzymes and everything else. Immunohistochemistry has to be done properly. In a nutshell, the biopsy, how we differentiate the biopsy is very important. So typically what we used to call polymyositis and a whole group of muscle diseases which are other than dermatomyositis, what you will find in the biopsy specimen is a preponderance of CD8 lymphocytes and also endomysial muscle inflammation in polymyositis or other group that we're talking about. And also you will find then upregulation of MHC class 1 in the group of people who are other than dermatomyositis group of disorders. Now, if inclusion body myositis is suspected, what you will find also, not in everyone, but later on, is a regenerative and degenerative process going on, maybe some neurological features, but the most important thing is the rim vacuoles. So inclusion body myositis is thought to be not only an inflammatory process, but probably a new degenerative process. So these rim vacuoles may actually, may in fact indicate that. The trigrome Gomori stain has to be done, and then you will find ragged red fibers in inclusion body myositis, in addition to the CD8 cells that we talked about and endomysial muscle inflammation. Now, dermatomyositis. Dermatomyositis, what you have to underline is that you will find perimysial atrophy. That's very important. You will find perimysial atrophy, and what you're going to find is more of the inflammatory cells surrounding the vasculature of the muscle. So some people say that dermatomyositis could be a small amount of vasculitic process can be going on in that as well. And the CD4 cells now, as compared to the CD8 cells, will find CD4 cells. So this is the very important part. I would also want to touch upon quickly on another group set of disorders, which is called immune-mediated necrotizing myopathies, because this is a very serious nature of myositis, where you will find a lot of necrosis going on, a lot of muscle necrosis going on. But at the same time, the inflammatory infiltrate would be very minimal. You're not going to find a lot of T cells, B cells. You're going to find a lot of degenerating cells, a lot of regenerating muscle fibers. And what you will find is probably a few macrophages engulfing, but not a lot of inflammation going on. That's why it's basically post-immune kind of a thing, where a lot of features are consistent with necrotizing myositis. So this is in a nutshell about what the pitfalls in a biopsy, how to properly collect the muscle biopsy, and how to properly process it, and how to properly look under the microscope. And every step of the feature is very important, because if you miss any step of the feature, then primarily what you will get will be a non-specific kind of findings.
Right, doctor. So, doctor, when we move into the immunologic biomarkers and imaging techniques, how this immunologic biomarkers and imaging techniques are related to disease activity in idiopathic inflammatory myopathies.
Very good. So that actually takes me to the next step, which was I was about to tell you, that how do we differentiate? So no more that we differentiate dermatomyositis and polymyositis. Pretty much now we do the antibody profile and the phenotype, the presentation of the patient, whether it's acute, whether it's subacute, whether it's slowly progressive, what age of the patient, and how they present is very important, because that will determine actually what we're going to do with the patient further on. And as you said, immunological techniques. So the first thing we're going to do is order other than the blood work that I talked about, the CPK numbers and stuff. For example, CPK numbers are very important. For example, if the CPK numbers are only slightly elevated, you should always include thyroid function test in that, because hypothyroidism can also cause muscle damage and mimic the picture of polymyositis or sometimes even rheumatoid arthritis. So TSH has to be done. Then the group of autoantibodies. So the autoantibodies now help us to differentiate the muscle disease into different groups. For example, one group of disorder we can say is dermatomyositis, which has got very typical skin findings of dermatomyositis. Sometimes there is a muscle involved, sometimes the muscle is not involved. But what you based it on also is the autoantibody findings. So the typical autoantibodies of dermatomyositis are MI2, which has got very good prognosis. Typically, it is the typical dermatomyositis where you're going to find Gotron papules, V sign, Scholl sign, and everything else that we know about dermatomyositis, the raccoon's eyes, and stuff like that. And it's got good prognosis. Then we have a group of autoantibodies which are called SAE, MDA5, and the two important antibodies which I'll touch upon in dermatomyositis are called NXP2 and TIF1 gamma. So TIF1 gamma and autoantibody can cause not only severe skin disease with a lot of skin findings, but you also can find very high risk of malignancy in this group of patients. So it's an antibody which is very strongly associated with either already existing cancer or a cancer risk that you have to explore in the first 2 years. So what's recommended if you find TIF1 gamma antibody or NXP2 antibody is that you should do a very thorough search for an underlying cancer. So the risk of cancer in TIF1 gamma is about 75% in the first 2 years, and NXP2 is about 30% in the first 2 years. So in addition to all the skin findings, muscle findings, what you have to do is do a very thorough search. So thorough search means that you have to do a CT scan. What is recommended is you do a CT scan of the chest, abdomen, and pelvis to look for any asymptomatic cancer in this group of disorders. Common cancer, as we know, is going to be lung cancer, breast cancers, and other group of cancers, colon cancers, and whatnot. So other step you can do is you can, if it's available, you have to scope the patients, send them for an upper scope, lower scope, and some of the physicians who work closely with these, they even say that you get a cystoscopy because sometime one of the speakers, which I heard about speaking about this, is that in one of his patients, he finally found a urinary bladder cancer where everything else was negative. So not only that you do this workup once a year, but then if you don't find it, you have to typically do this workup, if available, if possible, every year for 3 years, and for looking for any cancer. The risk kind of drops rapidly after that, after 2 to 3 years. So this is the dermatomyositis. Then there is a whole group of disorders called Antisynthetase Syndrome. What is common in them is an antibody called Antisynthetase Antibody. This is a syndrome where you'll find not only myositis, you can find dermatomyositis features, but you can also, there's a high risk for underlying interstitial lung disease. I have some very interesting cases which I've treated for interstitial lung disease, where they can just present only as interstitial lung disease with very less amount of muscle or skin findings. But in this group of disorder, which if you can find, you're going to find a very interesting skin disorder called mechanic's hands or hiker's feet. So although the patient is not a mechanic, you will find actually a roughened hyperkeratotic skin around the palmar area, especially around the fingers, the lateral part of the fingers or the thumb. It will look like exactly how a roughened skin of a mechanic or someone who works in an auto shop or something like that, although this person could be a professor or a school teacher or whatever else. So this is a very interesting finding, which could be a tip-off to antisynthetase syndrome. They can have Raynaud's phenomena. They can even have inflammatory arthritis, which can look similar to rheumatoid arthritis or other inflammatory arthritis. And autoantibodies, which are typically found in them, is Juvenile antibodies, which has got a good prognosis, typically less risk of cancer. There is two antibodies which are now more commonly being found, anti-PL7, PL12 antibodies, which high risk for interstitial lung disease, relatively worse prognosis because their lung disease is pretty difficult to treat. Then EJ and OJ in the South Asian population, ZO antibody, which a lot of work has been done in Europe, especially England, and then KS antibodies. This is in antisynthetase syndrome. MDF5 antibody can also be a part of antisynthetase syndrome. Then other group of disorder, which is very important, very quickly you have to diagnose and you have to treat it very aggressively, is a group of disorder which is called, as I said initially, immune-mediated necrotizing myopathies. Now, this immune-mediated necrotizing myopathies are important because they are very rapidly progressive. And the two antibodies which are more important. So there are three kind of things that you're going to find. One is SRP antibody. The other one is HMGCR antibody. And the third is where you don't find any antibodies. If you don't find any antibodies, typically can be underlying cancer or you just don't find anything. And maybe that antibody is yet to be discovered. SRP antibodies are very unique antibodies. In Western part of the world, mostly you find more in the African Americans. It is a very rapidly progressive muscle disease. It can leave you crippled in a very short period of time. And typically, the muscle enzymes are raised in high numbers, 15 times the normal or beyond that. And the SRP antibody, you have to treat it very aggressively with hydrosteroids. And I'll tell you about later on. But management is rituximab mostly you have to give. And the patient mostly also can develop swallowing difficulties and other disorders like that. And since you're giving hydrosteroid, you have to really watch out for infection rate in this group of people. The very interesting antibody here I want to discuss, and you should not be missing, is called HMGCR antibody. So antibody. So this is in like 15 or 20 years ago. What we knew that was that if you take statin group of drugs, which is basically very widely used to treat and lower the cholesterol and the lipid disorders. We can get like muscle aching, you can get even rhabdo, and you can get CPK raised. But typically, they were all reversible when you remove the culprit statin. But then suddenly we realized there's a whole group of people where you even remove the statins, it's the CPK will never budge, and they will develop a progressive muscle disease very similar to polymyositis or autoimmune myopathy. And finally, this antibody was discovered last 10, 15 years by mainly a group of Dr. Mammon and Dr. Lisa Christopher Stein from Johns Hopkins, and now we can easily find these antibodies in proper if a good lab is available. And if this the statin group of disorders, statin group of medicines can in genetically predisposed people can trigger this autoantibody phenomenon, not in everyone, but in a select group of people, where now even if you remove the statin, the damage of the muscle will continue, and you have to treat it in a very different way. Steroids again, but mostly in this group of disorders, IVIG plays a very important role, sometimes rituximab as well. So this is very important to remember. And when they looked at the statins, they found out that typically atorvastatin is more of a larger culprit compared to rosuvastatin and those kind of group of statins. And if you develop obviously this kind of autoantibody phenomena, you have to stop the statins. And if they have to treat hyperlipidemia in cardiac patients, you have to go with a non-statin drug, because reintroduction of statin can further make it worse. So you want to avoid this. Finally, quickly, I would like to touch upon the IBM, which is inclusion body myositis. Now we know that there is an antibody available called 5NT1A antibody, which is in some of the, it's not widely available. In some of the labs, when it is available, then highly probable that that group of disorder, if everything else is falling into picture, is an inclusion body myositis. And typically, the people who have this antibody have to be, they have worse prognosis compared to the one who do not have this autoantibody. Again, one overlap. So myositis not only is present in very specific autoantibodies, but in overlap syndromes. So overlap syndrome is very important because they still form a very large group of autoimmune myopathies, and you should know what autoantibodies to look for. So PMSCL autoantibody is where you not only that there's autoimmune muscle disease, but then you can find scleroderma-like features. I actually recently saw a patient in my practice where that particular patient was never diagnosed for years and years, had scleroderma features, but all the three autoantibodies for scleroderma was negative, which we know scleroderma 70, centromere, and RNA polymerase 3 were all negative. But when we ordered, because in this particular patient was very interesting because she had the mechanics hands, so we ordered them a myositis profile, and she had actually PMSCL antibody positivity. So this was indeed a scleroderma patient, which was missed over the years, had typical Raynaud's, had typical skin disease. They can even have arthritis, and they can have muscle disease. The prognosis of PMSCL antibodies is relatively much better than the other, the typical scleroderma, and they do not mostly get a bad lung disease, etc. Now, the other antibody which we commonly see in overlap syndrome, is called RNP antibody. RNP antibody means that it is a mixed connective tissue disease antibody, widely studied. We already know that you can have arthritis, myositis, scleroderma, lupus, or none of them, or all of them, or few of them features combined together. Rho antibody and co-antibody can also cause similar. So I'll stop there because it's getting a little heavyweight, and I know that probably for a lot of people it might not be that important. But for rheumatologists and the people who are really interested, this is how we now divide the myositis, and this is how now we kind of follow the immune features and findings, and this is how we treat them.
Right. Doctor, can you share your thoughts about the clinical manifestations of juvenile dermatomyositis?
Yes, very interesting topic again. Juvenile dermatomyositis. So in kids, you typically do not get polymyositis that commonly, and mostly what you get is a dermatomyositis, which is called juvenile dermatomyositis. So in kids, the typical age, I'm talking about the median age is about 7. Obviously, older can get that too. Mostly females are more than males, more white race compared to the non-white race. So what to remember very important in them is that yes, a kid can develop like a fever. So constitutional feature, they can present with fever, lethargy, lymphadenopathy, but the main feature finally is going to be a skin finding and a muscle finding. So the kid would be someone who will have the typical skin findings. So what are the typical skin findings? The typical skin findings are, you'll find not only that you will have, so Gotron papules. Gotron papules or Gotron sign is you're going to find erythematous lesions around the metacarpophalangeal joint, interphalangeal joint, DIPs. You can also find similar Gotron signs around the elbows, extensors. You're going to find in the extensor of the knee joints. So these are the typical Gotron papules. The other finding you're going to find is you can look for, there's telangiectasias, which can be pretty disabling, can be very widespread. And you can also find sublingual erythema and nail fold capillary changes. Other features you're going to find in the kids is that there can be a rash on the ears. There can be a rash on the face. And the face, typical rash on the face will, as compared to lupus, will not be sparing the nasolabial folds. The nasolabial folds will be involved. This is how you're going to be differentiating lupus with juvenile dermatomyositis. In juvenile dermatomyositis, one of the very disabling and one of the very differentiating features is that you will find much more calcinosis. So risk of calcinosis in kids is about 30 to 40 to 50%. And that can be pretty kind of cumbersome. It can cause ulcers, it can cause infection, it can cause contractures. So that is something which is more prominent in the kids compared to the adults. You can also find the V sign, Scholl sign. And one pathognomonic feature is that you're going to find eye frame-like, where you can have like eyeglasses-like frame-like features around the eyelids or eyes. Now, one very important feature to remember very important thing to remember in juvenile dermatomyositis is that the mortality is less than 5% compared to the adults, where it could be about 10 to 20% if you take all comers. Very, very interesting point in kids also is that in the kids, when you do the autoantibody profile, the autoantibodies you will find more commonly is called TIF1 gamma and NXP2, which in adults is a very high risk of malignancy. But in kids, they almost cause no malignancy. So very interesting point to remember that how the same antibodies behave very differently when found in kids as compared to the adults. You're going to find mechanic signs as well if it's an anti-SRP myositis in this case especially. And EMG is abnormal in more than 90%. You're going to get the muscle biopsy. And then in the kids to remember is that obviously the part which is very important is that emotional component. So not only that you will be treating patients, the kids especially with myositis, but you'll also be tackling their emotional component because the patients at that age are growing and they find themselves very different from the other kids. And so you have to really make sure that you treat the emotional component as well. One important thing to remember also is that in kids, later part one, when you even treat these kids and they get better, they can develop poikiloderma, lipodystrophy, and skin atrophy, which can leave them not only the physical but emotional scars for the rest of their life. So this is very important to remember. So these are a few of the points where the kids are a little different than the adults. I hope that answers your question.
Yes, that does, Dr. Shakib. So when we move on to the management part, what are the challenges you faced while treating?
Was everything recorded properly? Because I thought I lost you there for a while.
No. Everything is recorded properly.
Okay, good.
We are live.
Okay.
Yeah. So
please go ahead.
Yeah, what are the challenges that you have faced while treating idiopathic inflammatory myopathies?
So idiopathic, this is a very difficult topic in that sense, and frustrating topic in that sense that, first of all, the diagnosis of IBM is very important because sometimes it's not very easily diagnosed. As I said, that those rimmed vacuoles and those filaments that you find, the degenerative filaments that you're going to find on electron microscopy or otherwise are not easy to find. And many very good pathologists can even miss them in the beginning. So the diagnosis of IBM can initially be misdiagnosed at routine polymyositis, which is just not responding to the treatment. So typically the IBM, the most important first part is to make a proper diagnosis. So the proper diagnosis can take sometime even 5 years or more. So one thing to remember is that it's mostly always an older adult. Above the age of 45 to 50 is one of the hallmarks. CPK, the tip-off is that the CPK level is never raised up to the level of like 15 above normal. It's not like those group of disorders. So the CPK may be only partially or slightly raised or 500, 1000, nothing more than that. So that is one of the tip-offs. And the third thing is that the chronic features, so it has to be a weakness which is slowly progressive over the months and the years. And how the patient is going to present is very important because we know that typical dermatopolymyositis is more bilaterally symmetrical, mostly proximal muscles of the shoulder and the hips and stuff. In this case, it's opposite. Not only that you can have the proximal muscles, but mostly it is the distal muscles. So you will have a grip strength weakness, you will have the finger flexor weakness. Similarly, you'll have the knee weakness rather than, or ankle weakness rather than the hip weakness. So what the patient will tell you, one of the tip-offs would be a slowly progressive weakness in an older person where there'll be a lot of falls because the knees will buckle, the ankles will buckle, the grip strength, so the people will not be able to grip stuff. And they will be, when you'll ask them to close their make a fist, they will not be able to make a fist. And they'll be dropping stuff. So they'll try to hold different objects and they will be dropping those objects frequently. So they will complain about that. Similarly, they will not be able to get up from the chair. They'll not be able to climb the stairs. So this is in their history. And then obviously the next step is you're going to do the EMG. So why EMG is done in these cases is to rule out neurological versus, because it can have mixed pictures. So not only that it will be an inflammatory picture, but it can be a degenerative pictures. So the underlying pathophysiology is that not only that you can have, it's an inflammatory, slowly progressive inflammatory process, and the muscle biopsy typical to polymyositis, but there is degenerative features too. So you're going to find a lot of degenerative process going on, and these rim vacuoles may, in fact, point out towards that. So once you've made the biopsy diagnosis, which can take, as I said, many years, and most of the polymyositis, which were diagnosed late, initially may convert into IBM or better diagnosed in a repeat biopsy as inclusion body myositis. Now the frustrating point is that there are very few treatment availabilities. That very few patients who can improve with steroids even. So once you've made a diagnosis, the most important part is use steroids only in a select group of people. If you find that antibody that I talked about, or if there's a high CPK numbers, or you find that patient is relatively more progressive, then you can give the short trial of steroids, mostly prednisone, mostly 0.5 mg to 1 mg per kg, but just use it for the first 2 months. And if the patient is not responding, you have to taper it off, because then there's more risk that the patient can develop steroid-induced myopathy than any kind of a benefit that you're going to get from steroids. Methotrexate has been tried in the group of people where you find more, as I said, autoantibody features have been found, or it's a relatively more progressive disease and with more inflammation found, or high CPK numbers. Methotrexate can be tried, Imuran has been tried, Cellcept has been tried, even rituximab has been tried, but really nothing really has been very helpful. Studies have been ongoing for the treatment. IVIG has been tried in a select group of people where swallowing is an issue, and it may help in the very beginning if you try it early. And then what also is very important part of the treatment is that since the patient develops swallowing difficulties, so you have to get the GI people involved, cricopharyngeal muscle, myotomy may be needed, or you can do Botox injection in order to improve the swallowing. And in very rare cases, you have to go with a gastrostomy tube, but you know that how much morbidity and mortality can be associated with that. Now, the most important part of the treatment of IBM is involvement of physical therapist, occupational therapist, and speech therapist. This has to be involved very early. they have to get physical therapy on ongoing basis for the rest of their lives, and a home exercise program that they have to do, which we'll talk about later too. But this is a very important feature. If they have a lot of muscle weakness going on, you can give them the aids, for example. Many times starts with a cane, but they may end up getting a walker. Remember, this is a span of years. We're not talking about months or days. So sadly speaking, all of them will finally come to that they have to be given this different walking aids and different stuff like that. The braces have to be given so that they don't fall. So all these stuff and all these measures have to be taken. In desperate attempt has been made to give them creatinine phosphate. So creatinine products can be given like 3 grams per day for 2 to 3 months, and see if the muscle damage can be stopped, or some muscle mass can be obtained, or some strength can be obtained. So this physical therapy has to be done for most of their life, and it's a very important part. Speech therapy, occupational therapy, physical therapy, and as I said, GI can be involved if there is a swallowing disturbances. So this is in a nutshell. The studies even have been done with abatacept, and different biologics, and in some group of people it helps, but not in everyone.
Right, doctor. So, doctor, actually, this question is very interesting from a physician in Indonesia. It's like, what are the current treatment therapies for inclusion body myositis? I just want to add another question, which was from UAE, based on this only. That are there being a lot of research done in the recent times for inclusion body myositis in the aging adults?
Yeah, I mean, like there are, for example, there is a couple of drugs which were, studied. Dimigramab, there was a trial done on that with mixed results. Now, one thing actually, anakinra, IL-1 blockers, they are showing some promise. So I think the studies eventually will show that, the small trials have shown some initial promise. So in some of the group of patients, if anakinra or IL-1 blockers are available, then probably that can be tried. Studies have been done with natalizumab, which we know has been used for MS. So important thing to remember is that the antibody I talked about can not only be present in IBM, can also be present in some of the MS patients. So that's where the natalizumab trials were done, and with some benefits. So in desperate times, if it's available, that can be tried in a select group of people. Anakinra, I think, would be one of those drugs which shows some promise, and I see that in the future. No. So very recently, there is money is being collected to start doing some trials for gene therapy. So probably we can somehow do some gene therapy to help it out in a select group of people. So yes, we are trying to study a lot of different drugs, and different drugs are in the trials, but none of them have really been approved as such to be used. As physician, yes, we will continue to try different drugs. And I would highly recommend that if there is any clinical trial going on in one of the university centers closer to yours, where the muscle is, autoimmune myopathy is one of the topic of interest, I think you should definitely try to get these patients enrolled in those group of medical trials.
Right, doctor. So, doctor, how neuromuscular side effects induced by immune checkpoint inhibitors used for treating myositis are managed?
Yeah, immune checkpoint inhibitors. It's a very interesting topic to me because, about 8 years ago, 7 to 8 years ago, I had a patient. In fact, at that point, immune check inhibitors were new, and a patient coming to me for, inflammatory arthritis consult. I realized that when I was taking the history, one thing which was very stark or very hard hitting was that this patient was a cancer survivor from lung cancer, stage 4. And when I asked, how long have you, when was it diagnosed? He said like 4 to 5 years ago. And I said like, oh, let me look at how could she be surviving. So I said, this was the drug I was taking. Then I said, what if this drug actually could be a culprit? Just this thing came to my mind. What if this drug could be causing this inflammatory arthritis? Because the blood test and immune workup so far has been negative. I looked up the literature, and at that point, actually, immune checkpoint inhibitors related inflammatory arthritis, few case reports had been made again with Johns Hopkins. And since then, a whole group, now we know much more about these immune checkpoint inhibitors and their rheumatological manifestations. So the thing about immune checkpoint inhibitors is that the important thing to remember in them is that these are the group of. So what is immune checkpoint inhibitors? First of all, the immune checkpoint inhibitors is a group of medications. So our immune system, what is our immune system? Has T cells, B cells, and mostly our cancer cells get, immune surveillance, surveillance is going on all the time, for these, so that no cancer develops at any point, right? But at the same time, the immune system is kept in balance, kept in check by those immune checkpoints, where the T cells and the T cells are kind of checked so that they do not get into overdrive. So the important thing is that there should be a balance between them. So the underlying theory is that probably when the cancer happens, these immune checkpoints were really not letting the T lymphocyte cells to do the immune surveillance. So the blockers of these immune checkpoints have been, now we know that, are widely available in the good centers, where you block these immune checkpoints so that T cells can regain their function, and then they can do the immune surveillance, and then they can kill the cancer cells which are present there. So now we know that these immune checkpoint inhibitors, although very effective, but they can actually be also be a little bit risky because they can develop this immune system can go into hyperdrive, and then they can develop different disorders which are related to autoimmune phenomena. So dermatomyositis and polymyositis has been found now in more and more cases of immune checkpoint inhibitors where they were given, and then they develop this autoimmune phenomena and autoantibody phenomena. So this is some very interesting topic because they can develop the same kind of features that routine autoimmune dermatomyositis or polymyositis can develop. But the cancers are a little different. For example, melanoma and lung cancer, as opposed to colon cancer and breast cancer in case of typical dermato or polymyositis. So the problem here is that what are you going to do? You have to treat the cancer and you have to treat the polymyositis as well. So if they develop very disabling features, like, for example, if they develop, one of the things is that they can develop even vasculitis or cardiac myositis. So if myocarditis is developed, then you typically have to stop these immune checkpoint inhibitors, and then you have to treat the polymyositis because a person can die from myocarditis itself. So IVIG has been tried. Similarly, steroids have been tried. So first step, you have to give them steroids, and then you have to give them IVIG if the disease is mild and it's not disabling. But if the disease is severe, then you have to typically go all the way to rituximab. You have to give the cyclophosphamide. The CellCept can be given, and you have to go with your routine treatment of polymyositis and dermatomyositis. But it's a fine balance you have to maintain. The mortality is obviously very high. Morbidity is high because the patient already is immunosuppressed from the cancer, and also already is suffering from that part. So when you treat them with immune checkpoint, when you treat them for polymyositis and dermatomyositis, then you really worry about their side effects of the medications as well. So it's a topic in evolution, something that we are watching out for, and more studies are being done, more and more data has been collected. But yes, there is obviously definitely a risk for this. Now, another very interesting point that they're discussing is that is it possible that the patient already had a predilection or predisposition to developing polymyositis and dermatomyositis, and now with when you give them immune checkpoint inhibitors and the immune system gets revved up, and at the same time when the immune system is going to rev up, these autoantibody phenomena will get revved up, and that's why you see an unearthing of a dormant kind of autoantibody phenomena, which now is getting converted into a proper autoimmune muscle disease, just because this immune system was not triggered. So this is a nutshell about this phenomena. of immune checkpoint inhibitors. And we'll get to know more and more about it in the coming years.
Right, doctor. So, doctor, this question, I feel that, a lot of discussion is happening when we talk about precision medicine as a terminology. Now, what role can precision medicine play in the management of myositis, according to you?
Sorry, tell me more about precision medicine. What you mean by that?
Yeah, so this is majorly focusing on the targeted immunotherapy, which is developing majorly in the biologic space, as well as, sometime back we were talking about gene therapy also. Now, a lot of doctors are looking into a possibility where more precision-oriented, changes within the immunity can be targeted, which is already a part of rheumatology as an evolving science. But
I think what you
there is a promise.
So I definitely understand now what you're saying. So basically, targeted therapy. So targeted therapy basically is what we are doing in rheumatology in almost everything now. If you look at the rheumatoid arthritis treatment and management, if you really, this is what if I'm getting the right point from you, is that, in the beginning, we used to give them traditional DMARDs, disease-modifying agents, methotrexate, Imuran, azathioprine, which we call it, Celseptin, all that, some mycophenolate mofetil, which can actually have generalized effect on the immune system, but at the same time, you can have a lot of potential side effect on other organs, and then we developed this targeted therapy or biologic therapy where actual targets like such as TNF alpha, anti-TNF was developed, and then IL-6 blockers such as tocilizumab was developed, CTLA4 IVIG, where Orencia was developed, abatacept was developed, and then rituximab, which works on CD20 cells. So if you mean by that, yes. So this is what exactly I told about in case of inclusion body myositis, where disease is more frustrating. So we are targeting different immune cells. So that's why, and different, the cytokines, which are basically which trigger the inflammatory process, and downstream, they can cause a lot of inflammation. So that's why we are trying to target different portions of inflammation or inflammatory cascade, and that's why we have so many different targeted therapies, which we call now rheumatoid arthritis, also in lupus now with belimumab, and now we are developing that in autoimmune muscle disease, where we know that rituximab works, but we are also, as I said, IL-1 blockers such as anakinra is being studied for IBM. We also know that abatacept has been studied and has some promising results in autoimmune polymyositis, dermatomyositis. So more and more studies, and in some studies, even anti-TNFs can be given and can be tried. So yes, as we are going along in the next 2 or 3 years, probably you will find a lot of these targeted therapies and biologics available for, or recommended for, and more recommended for polymyositis, dermatomyositis, IBM, and all these different diseases.
Right, doctor. So, doctor, when we talk about dysphagia in inclusion body myositis, what are the general guidelines that can be followed for the treatment of dysphagia in this particular case?
Sure. So dysphagia is that if it's a mild dysphagia, as I said, we have to get the speech therapist involved and occupational therapist. So speech therapist will then do the swallowing analysis, how bad the swallowing is. Then they can obviously change the diet accordingly. They can give them the diet because the biggest risk with swallowing is that they can develop aspiration pneumonia. And the major cause of morbidity and eventually mortality in the patients who have IBM would be someone who develops this swallowing disorder, which eventually can lead to the aspiration pneumonia or microaspiration pneumonia, where eventually it can lead to death. So obviously they will give all the precautions, how to eat, how to keep the head of the bed elevated, how not to get the aspiration happen. They will do the imaging studies, dynamic imaging studies can be done, swallowing studies can be done. And then obviously, if it is something where help of a GI doctor is needed, they can, as I said, the surgeon can be involved also, where they can do the myotomy, or in very desperate situations, a GI tube can be given, gastrostomy can be done, or tubes can be given for feeding as well. Yes, so it will be treated according to how bad the symptoms are, or how rapidly progressive the disease is. As I said, IVIG can be tried as well, even in IBM, to see in the very early stage, so that we can probably stop this process or slow it down or get some beneficial results. Botulinum toxin can also be given for swallowing if there is a swallowing disorder going on, or if stretching of the esophagus is needed, then the GI doctors can be involved for the stretching of the esophagus.
Right, doctor. So, doctor, when we talk about juvenile myositis patients, how the side effects of steroids can be managed, in your opinion?
Yeah. So, steroid actually side effects are, as you know, that kids can get the. Sorry, 1 second. Let me. So, as we know that in steroids, steroids are very detrimental for the adults. They can be equally detrimental for the kids. The problem with steroids in adult, we already know. But now the kids, it's very important because we're giving the steroids them at very early age. In the adults, we know that they have a certain, let's say, a middle-aged person, 60, 70 years old adult is going to get, or middle-aged person is going to get high dose of steroids. We know that in 10 to 20 years, we can manage those. But remember, 7 years old, 8 years old, 10 years old, we gave them high dose steroids. So the side effect of steroids will be long-term in such kids. So the underlying two things you have to remember. If we can get away by giving prednisone rather than very long-acting steroids such as dexamethasone, betamethasone, that is the first step to remember. Try to use oral prednisolone as compared to long-acting dexamethasone, decadron, which we call it, and betamethasone. Then you will have less long-term side effect. And then use the steroid for a shorter period of time rather than put them on the steroid forever, because it has already been seen that if you use them for shorter period of time as compared to the longer period of time, then the risk, long-term risk, and even the short-term risks are low in these cases. For example, one of the things that we really worry about in adults as well as kids is called hypothalamic pituitary axis suppression, where we know that because of the supraphysiological doses that these patients are getting, the hypothalamus, which stimulates the pituitary, which then stimulates the adrenal glands, and the negative and the positive feedback mechanism to produce and regulate the steroid production in the body is disturbed, interfered with, and then this hypothalamus pituitary axis suppression can take many months to get back to normal. And in stressful situation, we know that we have to give them the rescue steroids. So this is important to remember that prednisone compared to long-dose, long-acting steroids, that's one step, and shorter period of time. The things that we see in kids by doing a retrospective analysis of all the studies where they were given steroids in the kids for a long period of time is seen that the weight gain is very so Cushing-Guide features, weight gain, and stunted growth. These are the three very different things that we see very commonly that we see in the kids as compared to adults is stunted growth. So the kids are in the growing age and they can get a stunted growth or delayed growth. So again, this is a problem where we get into the steroids and using them in the kids. One thing that I mentioned about is mortality. So when we reviewed all this literature, we found out that the mortality in the kids related to steroids is related to infections. And infections, not only the routine infections can happen, you can have opportunistic infections. You can have fungal infection. You can have TB infections. You can have more viral infections. So you have to make sure that you have to immunize the kids usually as usual, and also have a very low threshold of treating the patients, because we remember one thing, steroid can mask the symptoms of active infection. You're not going to get a very high fever. You're not going to get all the features of infection, so they can mask the features of infection. So you have to make sure that anybody who is showing any particular signs or symptoms which are compatible to infection, you have to treat them and make sure that they are properly covered with all the antibiotics or whatever particular infection you're worrying about. That's one thing. Also remember the emotional component. As I mentioned to you about emotional component, the patient can develop behavioral disorders. The kids can develop emotional disorders. They can even develop forgetfulness, dementia looking like features. They can develop mood disorders, depression, anxiety. So you have to make sure that you have to make sure the kid is a part of the routine life. He is studying properly. He's seeing a psychologist. He's seeing a psychiatrist if needed. They're properly treating him so that the kid does not feel emotionally any different than the other person or other kids. Other thing also to remember is that hyperglycemia can develop. So you have to make sure that their sugar level is being checked, because if they have any predilection toward developing of diabetes, it can unravel that, unearth that, and you can develop the diabetes so if the sugar is only temporarily high, you can let it go. You can make sure that you properly treat it, and you can get the endocrinologist involved in those kind of group of people. So you remember that steroids. So vitamin D and calcium has to be given in the kids. They are covered so that in the long run they do not develop osteoporosis as well. So these are some of the finer points that you have to remember in kids as compared to the adults.
Right, doctor. So, doctor, this one question is very interesting. Actually, it's been asked by a cardiologist. He has asked that can statin medications may affect or lead up to the cause of necrotizing myopathy in CV risk assessment cases.
So actually, this antibody I talked to you about, HMGCR antibody, in fact, is one of those antibodies. If you remember, is a group of the two antibodies that cause necrotizing autoimmune antibody. So immune-mediated necrotizing myositis develops in two kind of antibodies. One was actually the HMGCR, and the other one was the SRP antibody. So yes, statins is actually something which will cause necrotizing myopathy. So yes, that is a very typical feature of statin-induced myopathy.
Right, doctor. Doctor, why do you think there is occurrence of inflammatory myositis after COVID-19 vaccination? And if so, what treatment would you recommend for this condition?
Yeah, so again, that the COVID-19 is something which is causing a lot of different phenomena, and we still are studying a lot of different things which can be a feature of COVID itself or the vaccines. So vaccine I don't know about, but COVID-19 itself definitely can cause, for example, it can cause a phenomena similar to antiphospholipid antibody syndrome. We have found clots which are very bigger than unusual clots. Many cardiologists friends of mine have told me that they have found actually clots in the people who have had COVID, which are very different, large clots in the coronary thrombosis has happened, which looks very atypical in much younger patients. And then even it can trigger the antiphospholipid antibody phenomena. And we have found more antiphospholipid antibodies in the patients who had COVID-19. So similarly, more and more cases of now we are finding out, data is still being compiled, but yes, some cases of dermatomyositis and polymyositis are being discovered more commonly in people who had COVID-19. Because you remember, it triggers the autoimmune phenomenon in select group of people. Cytokine storm, for example. Cytokine storm is where there is a relentless amount of unchecked kind of cytokines, and that's where we give the baricitinib, and we give the Actemra, and so that's the underlying kind of mechanism. But yes, I don't know much about the COVID vaccine though, that if COVID vaccine can do a similar thing, but COVID-19 definitely can trigger a lot of autoimmune antibody phenomena, which can lead to more autoimmune disorders.
Right, doctor. Doctor, one of the doctors actually have asked, this is regarding one of the articles that you have created, which is majorly focusing on 5 ways to manage bad disc with rheumatoid arthritis. So the doctor has actually asked that what was the ideology behind that. He found that article very interesting in the recent times.
Tell me about it. Which article are we talking about? We are talking about the myositis or rheumatoid arthritis now?
Rheumatoid arthritis one, doctor. Yes.
So which article is he mentioning about this?
5 ways to manage bad disc with rheumatoid arthritis. It was published in April 29, 2019, last year. Yeah.
Tell me more about it, actually, because I think we are mixing up few things.
Yeah, sure. So majorly the pointers that was discussed in the article was the pain toolkit, followed by exercise as one of the medium that can help deal better with the patients, followed by assistive devices.
I think probably, yeah, he's probably mixing me up with someone else, because I think this was probably not published by me. It was something. We can later on look into that article if you tell me, and I can reach out to that person to answer those questions.
Sure, sure. One last question that, doctor, I would like to ask you is one of the doctors have asked that, in your opinion, what are the challenges which are faced in the management of myositis in head and neck region?
Head and neck region. So I think primarily probably could be from an ENT, ear, nose, throat doctor again. I think most probably, right? It's probably because the head and neck region, as I just mentioned about that, there are a couple of things. So one is that in some of these disorders that we talked about, in some of these antibodies, even the neck flexors can be involved. So, when you have a neck flexor involved, you can have difficulty in even, keeping your head straight. So you have to use, the assisted devices for that. You have to make sure that, again, the swallowing is proper. You're not getting aspiration and stuff. And sometimes IVIG and rituximab help for that. Then also, as we already talked about, the swallowing is the main problem in case of the head and neck region, that the swallowing phenomena, there's skeletal muscles involved in the swallowing, as we know, in the cricopharyngeal phase. So that can actually lead to difficulty in swallowing. And that's where I said that you have to get the speech therapist involved. You have to do the proper workup, which may include the EGD, which may include the swallowing studies, which may even need the imaging studies to be done to see whether there is anything else going on. For example, swallowing is not only a phenomena of myositis, but you have to rule out every other cause, such as there is not like any atresia developing, any kind of stricture has not developed. So you have to do a proper thorough workup. And if nothing else has shown up and it's all myositis, then you have to give them IVIG, because IVIG can help the swallowing disorders associated with myositis. And if IVIG does not work, then we go to the other desperate attempts we already talked about.
Right, doctor. Thank you so much, Dr. Shakaib, for helping us with the expert opinion on all of the questions collated from the doctors. As a takeaway, if I can ask you that, in an ideal world where we do have all the armamentarium with us, how do you look at myositis? In terms of having the optimum treatment done. Basically, I'm asking this question from a GP's perspective, because I think they're the frontliners for the routing.
No, absolutely. GPs basically are the backbone of medicine, because I call them the gatekeepers. They have a very difficult job to do, I must say that, because they have to almost treat everything. The smart GP is the one who basically knows when to refer the patient. So, and to the appropriate, because as I said, they are the gatekeepers in almost every country, and some of the remote areas, in fact, they are the only one who's treating the whole thing. So the most important thing is to make sure that when they're doing a workup of anyone who comes with a suspicion of myositis, is to make sure that the other causes are ruled out, especially the neurological causes are ruled out. For example, myasthenia gravis can also lead to some of the similar features, and you have to make sure that that in those group of people, you have to do the proper, like such as tensilon test. You have to do the antibodies that are related to myasthenia gravis. TSH has to be done. So for GP, they have a bigger work to done, because they have to rule out other causes as well. For example, muscular dystrophies, which is not even autoimmune phenomena. So you have to make sure that, and they're seeing almost every group of patients. They're seeing kids, they're seeing adults. So their job is, I know, very tough. So after doing all this preliminary workup, they have done the CBC, CMP, they have done the TSH, they have done the ESR, CPK, SGOT, SGPT, LDH. And if any of that phenomena, like for example, CPK is high, LDH is high, AST/ALT is high, you definitely want to quickly refer the patient to a rheumatologist, because then primarily the further job has to be done by the rheumatologist, so that they can make sure that proper biopsy is done and all. So I hope that all the GPs have done the proper legwork. They've already ruled out anything that mimics polymyositis, such as hypothyroidism, such as myasthenia gravis, such as muscular dystrophies has been done. The developmental disorders have been ruled out. So when they have been ruled out, they can make the life of a rheumatologist relatively easier. Then we can have a focused approach. We can definitely treat and focus our energies on treating the autoimmune phenomena and autoimmune myositis. But hats off to my primary care friends, my internists, because their job is tough. They're doing their horizon is big, their canvas is big. So I think if they can at least preliminarily rule out those things and then quickly refer the patient for further workup. Because remember, in polymyositis, whether in the kids, whether in the adults, very important thing is that you have to catch it early, because if the treatment is done early, you can save the muscle. And one very important part which we forgot about is the physical therapy. Very important. The physical therapy, as opposed to previously when we used to think that autoimmune muscle damage is happening, please do not do therapy. Let's just wait for the patient to get better. No, you have to start the physical therapy very beginning, because in old, immense data now we know shows that if you don't do physical therapy early, then the muscle damage is done and you cannot regenerate those muscle fibers. And if the muscle is replaced by fat, then you cannot do much. So early introduction of pharmacology as well as physical therapy is very important, because the physical therapy of the shoulders, of the hip girdles, the knees, the ankles, especially in the IBM we were already seen, has to be done from the beginning and then intensified later on as the muscle heal from the autoimmune phenomena. And this has to go on and on forever, because we have seen that the muscle get nourished more if the blood supply is better, if the physical therapy kind of regenerate the muscle, it can rehabilitate the muscle which is already saved, and then also improve the muscles blood supply to the muscles. And endurance exercises have to be included later on. Aerobic exercises have to be done. Dynamic exercises should be done. Rubber band exercises should be done. So all this should be done very early. One thing I forgot about the immune checkpoint inhibitors, which should quickly, one of the things that is one of the differentiating point from polymyositis is immune checkpoint inhibitors is that axial muscles can be involved. And so that is something to remember, that not only that the peripheral muscles are involved, but axial muscles can get involved too. And you can also have diplopia. And, so those are some of the things that immune checkpoint inhibitors may be different than others. So just a side point that I forgot to mention.
Yeah, I think Dr. Qureshi, you very rightly highlighted the point that the journey of a patient starts from a GP, and from there it grows and it branches out also. So one of the focus that we have been with you is like when we talk about more into the decoding of the patient journey, so that each checkpoints have their own literature learnings of how to mitigate the patient in the right direction. And thank you so much for sharing your deeper insights. And I would like to especially thank all the 1,300 physicians who have currently joined with us for this live session across the globe from various time zones. And I think that is the best part about this particular session, because every physician has found some value in this, and I'm pretty sure that will help in their day-to-day clinical practice and enhancements also. Just to inform the participants that going ahead, we will be having more sessions with Dr. Qureshi, because this is a masterclass series that we have initiated now. And if you have any particular therapy in mind which you would like Dr. Qureshi to deep dive on, please share those with us with our internal poll surveys also, which will be conducted in the next week. So thank you so much, Dr. Qureshi, for being a part of this session. And as always, it has been a great session with you. And we look forward to more sessions going ahead.
It's my pleasure. Your team is amazing. I always feel very thrilled, very excited when it's any session with you. And also, I want to thank those 1,300 physicians who have logged on, because it's a weekend and they have taken time out of their precious schedule of the weekend with their kids and the family, the work schedule. So I really thank them for tuning in, and I hope it was useful for them. And let me tell you one thing, that rheumatologists cannot do it alone. We need your help. So all the specialties here are very important: GI, internists, family practice, pathologists, surgeons, anesthesiologists. So it's a teamwork, remember. And then our physical therapy friends. So remember that this is very important: speech therapy, physical therapy, that we cannot do it alone. In order to make the patient better and give them the best care, we need your help. And then we need the help of MedSynapse to spread the message, to spread all this information. So thank you to you too.
Thank you so much, Doctor, and thank you all the participants, and we look forward to connecting with you soon. We will keep you updated about the updated series also, which will be next in line. And also, this particular webinar is now available on the archive version. So please share it with your peers and request them to join the recorded version for their therapy shipping on MedSynapse. Thank you so much, and a pleasant evening to all. Thank you, Doctor.
All right, take care. Thank you very much. Bye.